So I wrote this question because I think it really forces you to understand physiology and pathophysiology of two high-yield disease processes, liver disease and DIC. So our patient has a MELD score of 20. The MELD score is calculated between 6 and 40. 40 is as high as you can go, is as bad as you can get. So this patient has pretty bad liver function. Remember, our liver makes a lot of our clotting factors. So if we don't have our clotting factors right, that PT will be elevated and that PTT will eventually be elevated too, right? Also with the liver, when we get destruction, we can lose thrombopoietin, which is a stimulus of the bone marrow to make megakaryocytes and then platelets. And in patients with severe cirrhosis, we can get portal hypertension, eventually hypersplenomegaly, and the platelets can get stuck in the spleen too. So we're losing platelets, we're losing clotting factors, and it can present like a DIC type picture. Remember, in a patient with cirrhosis, they'll have elevated estrogen because the liver can't break it down. So we can see the palmar erythema, we can see spider telangiectasias, we can see gynecomastia, things like that. So with regards to DIC, remember this can be due to an underlying cause. Things like sepsis, pancreatitis, some cancers, traumas are going to be the biggest ones. And DIC is going to be caused by, or it's going to cause a overactivation of your entire clotting cascade and your platelets. You're going to form huge thromboses everywhere, and then we lose all of our clotting factors and platelets, so it becomes a consumptive coagulopathy. So then the patient ends up bleeding out because they don't have any more functioning coagulation factors or platelets, okay? So again, the PT and the PTT are going to be elevated, and in the labs I gave you, right, the D-dimer is elevated, and your platelets are low, and the fibrinogen is low, right? But the fibrinogen is going to be low in both severe liver disease and in DIC, and that's because fibrinogen is made in the liver, right? So in this case, right, I don't really need to understand why this patient is bleeding out at this minute, right? We need to save their life, so that's not important right now. And the American Society for Liver Disease and the American Gastrointestinal Society both suggest we give the patient cryoprecipitate if their fibrinogen level is less than 100 and they're actively bleeding, which they are, right? So we would give them cryoprecipitate. Cryoprecipitate has factors 8, 13, von Willebrand factor, fibrinogen, and fibronectin, right? So we're doing guideline-based medicine. We can then send off a second lab to determine, okay, is this due to liver disease or is this due to DIC, which is what I was asking you. That lab that we would want to get is factor 8 levels, right? Factor 8 is a coagulation factor, but it's made outside of the liver. So if the patient has liver disease, factor 8 should actually be normal or even high. If it's DIC, they've used all their clotting factors, right? Including factor 8, so factor 8 levels should be low. The reason we do this is to then decide, okay, do we need to treat them down the road as DIC and find the underlying cause, or is this due to their liver disease? One final integration question. What if you get a patient, maybe they're a younger female, they present with kind of fatigue, dyspnea, you do a full workup, you do a peripheral smear, you see hour rods, and with the hour rods, we also do a genetic analysis, and we see a T1517 presentation. You remember that this cancer is associated with DIC. This is APML. What's the treatment for APML? So that's going to be all trans retinoic acid and arsenic trioxide. And then one more thing you want to know about APML is if we give the patient the treatment, all trans retinoic acid or arsenic trioxide, it takes all of these promyelocytes and it activates them, it differentiates them into their mature neutrophils. That's a huge immune response. It's going to cause a huge inflammatory storm, a cytokine storm, and the patient may present with what's called differentiation syndrome, where they may have pulmonary infiltrates, dyspnea, fever, hypotension, and end organ damage, maybe like confusion or an AKI. We're going to treat these patients with dexamethasone. Usually we don't stop the all trans retinoic acid or arsenic trioxide unless it's like the patient is like severely ill. All right, so that's liver disease versus DIC with a little integration.